Male reproduction. So as an overview, we're going to be looking at the development of male reproductive organs in utero, and then we'll get into the basics of anatomy and physiology of the male reproductive system, followed by spermatogenesis, or how sperm are made. And then we'll look into fertility considerations, which is one of the main ways that we can apply our understanding of the male reproductive system just in our everyday role as midwives. And then we'll get into all the hormonal side of things ever so briefly to finish up. In considering normal sexual development, we can break that down into the following. So for chromosomal development, we're considering, does this fetus have two X chromosomes, one from mom, one for dad, or an X and a Y, one from mom and then the Y from dad. So that would be determining baby's sex, would be chromosomes. And gonadal development, we're thinking about the development of either testes or ovaries. And for phenotypical development, generally speaking, that's going to be in line with the chromosomal development, but not necessarily. So that's going to be the appearance that this newborn has. Are they clearly female? Are they clearly male? And generally speaking, that's going to align with whether they had an X or a Y chromosome. As the, guess I should clarify. So mom's always giving an X, and then dad is either contributing an X or a Y. If dad contributes an X, then we have a girl. If it's a Y, then we have a boy. So if we have an XY, we're expecting phenotypical development that will be male. Versus two X's should be female. And then finally, neuroendocrine development, we're basically thinking about puberty, where sexual development is essentially paused after the birth until puberty hits, and then we have continued sexual development under the influence of hormones. So that's where the neuroendocrine piece comes in. So for thinking about phenotypical differentiation between male and female, first of all, that initial development in utero is the same, whether we ultimately end up having a sex that's female versus male. And the default for all babies is going to be female, so unless there's this small portion known as the SRY portion on the end of one of the arms of the Y chromosome, if that piece is not present, then automatically we're going to end up as a female. And then if that piece is present, along with appropriate testosterone production and testosterone receptors, then we will end up as a male. So there are two pairs of ducts that are present in male and females. The Wolffian ducts are associated with males, and the Mullerian ducts are associated with females. And you can picture those two little German dots over the U of Mullerian if you would like. So Wolffian male, Mullerian female. And the default is for Mullerian ducts to just be on autopilot to have female development occur in utero. And in order for the Wolffian ducts to be activated, we need the SRY portion of the Y chromosome. So SRY begins this process of cellular reorganization, so ending up from what starts looking like it's going to be female gonads into male gonads and genitalia. So the SRY portion of the Y chromosome is going to activate the Leydig cells, and they're going to proliferate and ultimately produce testosterone. Excuse me. The testosterone is going to act on Sertoli cells. This is within the testes. And the Sertoli cells, in long term, we're thinking about spermatogenesis, that's their biggest role, but they have receptors for testosterone, and then ultimately, which is what would set off spermatogenesis, but then within the context of phenotypical development, they produce MIH, also known as Mullerian inhibiting hormone, which inhibits the Mullerian ducts from creating or leading to female genitalia and gonad development. So then just looking at testosterone that's made by the Leydig cells, they would stimulate the Wolffian ducts for the male genitalia, and then they also, the testosterone itself breaks down into dihydrotestosterone, which is responsible for external genitalia development, as well as thinking about puberty down the line. So you can see in this image here, we start with an undifferentiated fetus as far as their genitalia goes, and we have our glands, and then we can see the genital fold here, and then the groove would be that empty space. And the glands pretty much are running also in the inner portion here that we can't see, kind of in the abyss, if you will. So for male differentiation under the influence of testosterone, the glands are going to elongate, and then this urogenital fold here on either side is going to pull forward and basically zip right up the front here. So you can see that here, we're just zipping right up the front. So it's that elongation and then the zipping. And then also with testosterone, what was our ovaries are going to work their way down and then end up in the scrotum. So testicles will be descending under the influence of testosterone. And the tissue type, you can compare male versus female here. So the glans penis would be the equivalent to the clitoris in women, and then the scrotum would be the equivalent to the labia majora as far as tissue type goes, along with the shaft. So the shaft and the scrotum are the same as the labia majora. Okay. And I've just shown here that zipping up of the urethral fold fusion. This is A to B is just 1 day different. So this is going from day 27 to day 28, which I think is pretty incredible. You can see that. That's an image in utero. So just briefly touching on birth defects for some of the most common ones that are related to development. Hypospadias occurs when there's an issue with the urethral folds joining together in that zipping up motion in early utero. So that could be due to inadequate testosterone, lack of adequate androgen receptors, but typically we don't really know why it happened. So it would be, what you would see on the newborn exam then would be an opening on the ventral side of the penis. So you can see here, this would be considered a posterior one, a middle one, or an anterior one. And most commonly, it's more towards the top that you'll see that zipping. Here you can see one in the middle where there's 2 streams of urine. So that would just be something to note in your newborn exam for the pediatrician to follow up on. It's considered a pretty minor birth defect and it's pretty easy to correct with surgery. So if you think you're suspecting a hypospadias, one thing that would be important would be for you to hold off on having the baby circumcised, because sometimes they can do the 2 surgeries at once and they can use the foreskin to help make the repair on the hypospadias. And sometimes it's hard to find it, like it might be if you have an uncircumcised penis, which when you're doing a newborn exam, it's always an uncircumcised penis. Sometimes it's hard to really locate the urethral meatus and it might be hidden under the foreskin. And then the other common birth defect I wanted to note here is cryptorchordism. The incidence is about 1 in 50, and basically it's when our testes fails to descend all the way into the scrotum in utero. So you can see it starts up here about the height of where our ovaries are, and then comes down the inguinal canal, and then ultimately down into the scrotum. And usually this takes place at around 26 weeks gestation, and the journey from being up in the abdomen down into the scrotum typically only takes 2 to 3 days. And then once it has settled in, usually somewhere around 32 weeks, the inguinal canal will contract around the spermatic cord to prevent the testes from ascending back up into the abdomen. And something to just think about when you're doing the newborn exam is you would want to just give some pressure to whatever side you're feeling for with one hand. So I would put like I'd put 2 fingers from my left hand down here on the inguinal canal area, before using my other hand to palpate to see if the testy is there, because I wouldn't want to inadvertently push it back up in the process of seeing if I can feel and find it. So you kind of ground yourself by pressing down here and then feeling for the testy. Okay. Okay, so more common with prematurity, so maybe we haven't had a chance to make the journey down. And then breech presentation. Sometimes, I mean, if you just have a lot of pressure up here on your bottom, it might be too much pressure from settling into the pelvis. It might be too much pressure for the testicle to be able to descend down. And usually it is only going to take a few months for it to make its way down after the birth if it's not already there. So that's not something parents should be concerned about. Just letting them know that most end up descending within the next few months, and then just making a note for the pediatrician so that they can track it and make sure it does come down. If the testes hadn't descended after a year, that would be an indication for surgical correction, because down the road it would be at increased risk for malignancy or for infertility issues if it wasn't surgically corrected. So testes want to be outside of the body because being internal is too hot of a temperature for sperm to be developed appropriately. So they need to be outside of the body. Okay, so looking at penis anatomy as well as really our whole male reproductive tract here. So sperm are made in the testes, and then they get sent to the epididymis, and then they travel through the vas deferens and seminal vesicles. So we have two so far. We have vas deferens coming off of both of our testes, and then we're almost to the point where they're going to join. So seminal vesicles are going to add the majority of the fluid that contributes to semen. And then they keep coming down here, and this is where they're really joining, is right about here. And I've put this picture here to kind of blow that up a little bit more. So the seminal vesicles are contributing extra fluid, and then this is the point inside the prostate gland where both of them are coming together, and then this is your urethra here. So this is now a place where both urine and or sperm could be traveling along with the semen. So the ejaculatory duct, you probably can't see it very well, but it's right here. Basically, the ejaculatory duct is ensuring that sperm is not going up into the bladder, so it keeps everything headed in one direction, if you will. So the prostate gland adds more fluid to the semen. So majority seminal vesicle. Next runner-up would be prostate gland. And then you can see it passes this Cowper's gland, also known as the bulbourethral gland, and that adds some extra mucus, which typically gets sent out before the sperm get there, so it's kind of like it lubricates the pathway. And then this is our urethra that's running through this corpus spongiosum. And then, so this would be the ventral side of the penis, and then this corpus cavernosum would be the dorsal side of the penis. And then I have that cross-sectioned over here. So our two corpus cavernosum are on top, and then our corpus spongiosum with the urethra running through it on the ventral side. So dorsal side, ventral side. And in the event of an erection, these areas are what get really firm, whereas the corpus spongiosum stays soft so that it doesn't occlude the urethra. And you can see there's a lot of blood vessels that come in through here, which play a role in engorgement. And then I might not have another slide on this. So this would be your glans penis, and this would be your shaft, and then this would be the coronal area, would be the portion just right on the edge here, all the way around. And then the prepuce or the foreskin would be covering this area if it's present. So then looking at our testes, they are located within the scrotum, which you can see here. And the scrotum will have the testes and the epididymis, which you can see featured here a little bit better. So you have your testes, the pink area here, and then the epididymis is running all across the side here. And then your spermatic cord would also be within the scrotum. So let's just pause and think about muscles first. So you have two main muscles here. You have your cremaster and your dartos muscle. So the dartos muscle is just wrapping around it, all the way around it, and it contracts and expands. And then the cremaster muscle is running up and down. Oh, and then you can also see the dartos is further out. So the cremaster is really directly covering the testy here, whereas the dartos is wrapping more around the outside. Okay, so the cremaster is running up and down, and its main purpose would be to contract and lift the testes up for cold protection. So remember we said that the testes, they're super sensitive. So if they're inside the body, that's too hot and the sperm will die. And then if they're outside the body, then that's just right. But then if you end up in really cold temperatures, then the sperm will die again. So really sensitive. So if it's cold outside, the cremaster will contract and pull the testes up closer to the body to keep them warm. And the right testicle, this isn't really seen well here, but it hangs lower than the left one. So the nice purpose that ends up serving is if they should be hit from the side, the two testes aren't bashing up directly against each other, because that could lead to injury. So when we're thinking testes, we're thinking really sensitive. So sperm are created within these lobules, and then to be more specific, it's within these seminiferous tubules. So we'll see a cross-section of these seminiferous tubules on the next slide. But sperm are created towards the outside, and then they work their way to the inside. So seminiferous tubules then lead to straight tubules, and then that leads to the rete testi, where it's sent over to the epididymis, and then they come all the way down and then join into the vas deferens. So here's our vas deferens, and then go up the spermatic cord. So the spermatic cord would hold the vas deferens, and then the testicular artery, lymph vessels, venous plexus, and then there's three coats. So the outer part is the external spermatic fascia, and then we have that cremaster, the muscle that's running up and down, and then an internal spermatic fascia. So that's what's comprising our spermatic cord. And the scrotum itself tends to be darker or pigmented, and it's a really thin tissue that's rugated and generally has sparse hair. And as we've already alluded to, it's rich in sensory nerves. So it needs to be, because it needs to be able to perceive pressure, pain, temperature, etc. in order to keep the testes safe. So touching on the glands and the ducts associated with the male reproductive system. For ducts, we have the vas deferens that are carrying the sperm from the testes or the epididymis, both of them, over to the urethra. And they accomplish this through peristalsis. And then we have our ejaculatory duct, which we already touched on. It would be considered part of the seminal vesicles, and it helps to push semen out the urethra and ensures that it doesn't enter the bladder. If somebody has had surgery in that area, sometimes it's injured, and then that would be what could lead to retrograde ejaculation, where it is entering the bladder. But its purpose is to prevent that. So the prostate is adding about 30% of the seminal fluid, and it also includes calcium and enzymes. And then the seminal vesicles, it's about 70% of the fluid that makes up semen, and it's alkaline, which helps to support the sperm. The vagina is definitely more acidic, which is harmful towards sperm, so the seminal vesicles help keep sperm alive, essentially. So it's neutralizing the vagina to protect sperm and motility. And that's something worth asking a woman if you're going to check the pH of her vagina for whatever reason. Asking her if she's had sex recently would alter your nitrazine test results if you were checking in on what the pH of her vagina was. So something to keep in mind. And then the seminal vesicles are also making prostaglandins, which help to decrease the viscosity of semen, which is going to make it easier for sperm to swim and eventually get through the cervix. And then prostaglandins also serve to cause a reverse peristalsis within the uterus, which helps project sperm up into the fallopian tubes, which is one reason why we think about sex as being helpful in getting us in the direction of labor. Those prostaglandins could serve to help ripen the cervix as well as cause contractions. And then last but not least are Cowper's glands. They're secreting a thin mucus into the urethra that's going to help with lubrication. And then we can consider it pre-ejaculatory fluid, which would be better for sperm to get through. So emission versus ejaculation is an important concept to understand. Emission is going to be the discharge of seminal fluid into the posterior urethra. So nothing has left the penis yet. And then ejaculation would be the propulsion of those secretions down and out the urethra. For families that are choosing the withdrawal method as their form of birth control, it's relying on men being able to tell when emission has taken place before ejaculation happens. And some men can tell that pretty easily, whereas others, if you can't tell when emission has taken place between emission and ejaculation, that would make you a terrible candidate for the withdrawal method. So for those that can tell and have the self-control, that would be a very effective form of birth control. And we'll talk about the difference between perfect use and actual use once we get into birth control. But the perfect use of using the withdrawal method would make a lot of sense because nothing is ever coming out. So spermatogenesis, we have three main phases. So we have the mitosis, and then meiosis, and then there's the spermatid turning into the spermatozoa. And you can see here that you start with one male germ cell, and the end result is 4 sperm cells, whereas with oogenesis with women, we start with one germ cell, and then every time we have these divisions here in meiosis, we end up with this little polar body that gets dismissed, and then same with the second meiotic division. So the end result for oogenesis is 1 ovum, whereas with spermatogenesis we have 4 sperm. So this is our epididymis, our testes, and then here we can see our seminiferous tubules. There's tons and tons and tons of them. And if we do a cross-section of a seminiferous tubule, we can see how spermatogenesis is taking place. So there's 2 main layers. There's the basal layer and the laminal layer. So this is your basal layer on the outside of the seminiferous tubule, and the laminal layer is in the center. So all the germ cells, or the primordial germ cells that are going to become sperm, are located on this basal layer, and then they develop, and turn into sperm by the time they get to the lumen. And then they would go through the tube, through the straight tubules after they get through all the seminiferous tubules, and then here's your rete testes, and then up to your epididymis, and then here's our vas deferens, and we're off. This whole process takes 70 to 80 days. So this whole basal layer is comprised of germ cells, and some of them are going to just serve as stem cells forever. So they'll keep undergoing mitosis, but then they'll never go through all the ropes of ultimately becoming a sperm. So, or 4 sperm, so any one of these would result in 4 sperm. Whereas some of them will then go through the ropes of going all the way down and becoming a sperm. So we see here we start with a primordial germ cell, and then mitosis happens for a while, and then we have our official mitotic division that's getting us separated into 2, which this is really where we're starting here. So this is what's ending up being 4. So this is called a spermatogonia, and then that's going to become a primary spermatocyte, which will then divide into 2 secondary spermatocytes. That's the first meiotic division, and then it will undergo the second meiotic division, and then we end up with 4 haploid cells. And actually, these two would both be haploid too. So under that first meiotic division, they're haploid. And then that second meiotic division, then it's 4 haploid cells. And then we have our 4 sperm. So I'm just going to show that to you in one other way here. So we started with our spermatogonia. So here on the left column, I've put how many cells we have. So we start with 1 spermatogonia. It's a diploid cell, which means it has 46 chromosomes. That's complete. And it's just constantly undergoing continuous mitosis, and that's beginning at the basement membrane. And then we have one that says I'm going to go through and jump through all the ropes, and we're calling that our primary spermatocyte. And that's going to undergo meiosis, and then that will lead to secondary spermatocytes. And under meiosis, then we become haploid cells. So we have 2 23 chromosome cells. And so that's what this 2 is connecting to. I think that's a little bit tricky to see. And then that's going to undergo the second meiotic division, which will produce 4 spermatids, still haploid, and then those are going to become spermatozoa, or that mature sperm. And the only difference there to get from a spermatid to a spermatozoa is adding the tail, essentially. So again, that whole process takes 70 to 80 days. And here is our sperm cell. And you can see here we have our nucleus in the head of the sperm. So that's what's containing our 23 chromosomes. The whole point of this entire cell is to see if we can get the 23 chromosomes inside this nucleus into the ovum. So how is it prepped to do that? So our head contains our chromosomes, and then it also contains this acrosome layer at the top, and it has enzymes in it so that when it penetrates the ovum, it can help break it down so that we can get these 23 chromosomes inside. So after the head, we have our midpiece, which is basically our powerhouse center. So it's full of mitochondria, and we need mitochondria in order to power this flagellum, or this tail, because we are not going to be able to get those 23 chromosomes across the distance without having a good mobility factor on our side. Okay, so implications for fertility. When we're thinking about our testes, we talked about heat. So I think about couples that are having a hard time conceiving, asking if they have their laptops on their lap all the time, or if they're in hot tubs for a long time. Also thinking about constriction, whether that be tight pants. I guess that's the main thing I think of for constriction, or any kind of injury. So asking about a health history, like cryptocoridism would be an example, or if he played aggressive sports and there was an incident, whatever that might be, asking about injury. And then implications for fertility. If somebody has a vasectomy, just understanding that that's cutting right here on the vas deferens. And after that's done, there could still certainly be sperm all the way through here that hasn't been released yet. So generally speaking, I don't think I meant to put sperm times 3 months. Oh, well, you have sperm times 3 months. I guess that is what I meant to put. So as soon as the operation is done, you do not assume you're good to go, because there can still be sperm here. So you would say, like, waiting an additional 6 to 8 weeks, or 12 to 20 ejaculations, something along those lines, before you could feel fairly confident that the sperm count was going to be basically nothing. And it would be a good idea to go ahead and get a sperm count and make sure that it's negative after that time has passed. And then just realizing that after a vasectomy, somebody will continue to have ejaculate, because the prostate gland and the seminal vesicles have not been cut off from this process. So even though sperm can't get to the vas deferens anymore, you still have seminal vesicles creating fluid, in the prostate gland creating fluid. Cowper's glands would be right in here creating fluid, and all of that would still happen in the event of an ejaculation. And then implications for fertility, you could certainly collect a semen analysis and see what the potential there is, and then considering a varicocele just so long as we're thinking about male anatomy. So I have pictures of those coming up. So semen analysis, I've written down the composition that we've already talked about here for what's comprising it. So you can see here what is looked for when evaluating a semen analysis. So we can see our pH is much more alkaline in the vagina. That's going to be more around 4, 4.2. And then I think this is interesting, morphology. In order for it to be considered fine, you want at least 30% normal with WHO criteria or 14 with Kruger. So it's pretty common for sperm to not all look like a classic sperm. If only 30% need to look normal, you could have all sorts of interesting looking sperm also present. And it's important to note that a healthy sperm that's a normal morphology is far more likely to end up making it to the ovum. So if you have two heads, it's going to be heavier, same with this one, and it's just going to be harder to swim your way up more. Or this looks like a confusing coordination of flagellum to get there. Or this might not have the right kind of DNA to guide the cell well. So generally speaking, it's a healthy morphology sperm that's going to get to the egg, which should play into how we counsel as far as chromosomal abnormalities go. It's a lot less likely to be a male issue in that respect, because the ones with tricky chromosomes are making it to the ovum. And then a varicocele, just to see briefly here, that's when you have leaky valves that are causing backflow of blood and dilated veins within the spermatic cord. And because of that, that can lead to increase in temperatures in the scrotum, which can cause injury to the sperm. And then there's also been some talk about changing renal and adrenal waste concentration, which can affect sperm development as well. So basically you have abnormal blood flow, which interferes with testosterone concentrations. And generally speaking, it can oftentimes just be subclinical, so we're just detecting it on ultrasound in an infertility workup. And then generally the treatment is just going to be a varicolectomy if sperm counts are low, and it can take 6 months to get those levels back. So just to be aware of that. You know, if you're doing a semen analysis, you're looking at what's been present for the last couple months, because it takes 70 to 80 days to make sperm. And in the same way, if you fixed your problem, it can take quite a few months to get back on board to where you were before. And you can see higher rates in infertile males. And I'm not going to touch on this too much, except for just to understand that a similar process is happening here that we had with our ovaries communication with our pituitary gland. So anterior pituitary here is once again releasing FSH and LH, and they're so this is your FSH and this is your LH. And long story short, they're both working within the testicles, particularly the Leydig and the Sertoli cells, to help produce testosterone ultimately, and then higher levels of testosterone are coming back up here to affect GnRH, as well as directly to affect the anterior pituitary gland in terms of how much is released. So that's the checks and balance associated with testosterone, among many other hormones, which I will let you read about in more depth in Blackburn. And then when we think about testosterone's effects in the fetal period, it's helping to develop male sex organs, as well as helping with the descent of the testes. And then after puberty, it is a huge role in affecting spermatogenesis, working on the Sertoli cells that are right around the seminiferous tubules. So that's where it's being released. And then, that's Sertoli cells are what is receiving that the concentrations of testosterone. So the receptors are on the Sertoli cells. Testosterone is produced by the Leydig cells. Okay, and then it plays a role in enlarging genitals, body hair distribution, baldness, hypertrophy of the laryngeal mucosa, which would lead to a deeper voice, as well as the characteristic Adam's apple, increase of sebum production, increase in size and strength of bones, protein anabolism, which is going to play a role in the basal metabolic rate as well as red blood cell production, increasing libido, and then possible role in aggression as well. So just a brief overview of hormones, and I would really encourage you to read up more on that in Chapter 2, which you already read last week, so that's nice. But especially paying attention to hormones, paying attention to puberty and aging effects. If you have any questions, you know how to reach me. Have fun studying.